and Dr. Andrew Mendonsa. He oversees the clinical and program operations in the Sacramento County Substance Use Prevention and Treatment Unit. For over 15 years, Dr. Mendonsa has been actively involved in the fields of substance abuse, mental health, and forensic psychology, and is considered an expert in these fields. He has worked in settings including inpatient and outpatient substance use abuse treatment, state hospitals, jails, juvenile detention facilities, locked treatment units, and segregated housing units within local and state systems. He is licensed to practice in over a dozen states. Dr. Mendonsa has presented topics around the nation and the world, including Canada and Europe. And so today he's going to speak on a very important topic on self-care and professional preservation during a pandemic, and ways to identify burnout, secondary trauma, and techniques to remain resilient. So please welcome Dr. Mendonsa.
Hi, thank you so much for the warm introduction. Can everybody see my screen okay? Good. All right. Well, thank you. It's an honor to be here. I love the work that we do here on the Opioid Coalition. Super excited to be invited to present this topic. It is a topic that I'm passionate about. Anybody who knows me knows that I've been presenting on this topic well before the pandemic happened. And definitely now more than ever, we need this information. And so what I'm going to talk about today, this is a truncated presentation that I've done before that's over 3 hours. So I am putting a lot into a little less than 30 slides. So I'm going to give you a bunch of resources, a bunch of areas to get some new information, additional information, and then my emails at the end. Most of you know me, but feel free to reach out to me. I can put a much more in-depth presentation together for you or for your organization, share a ton more information for you. But this is really kind of a superficial, kind of a really 30,000 foot look at the topic. And so this is my kind of my little catchy topic that I like to use. As you know, we all have battery anxiety when we see our batteries getting down to 15 and 10%, so on and so forth. And so sometimes we're more attentive to our phone batteries and our phone percentages, but we're not too attentive to ourselves. So we really want to pay attention to ourselves and how self-care is important and how burnout can really sneak up behind us and not even see it coming. So one of the greatest quotes that I've seen, and it really kind of highlights really what I'm trying to get across today to everybody, is the utilization of early screening tools, self-assessment, and supervision strategies really can reduce burnout and early career departure and improve your professional career satisfaction. I'm very fortunate to supervise a super great team here in Sacramento County. In addition to that, I do some other supervision outside of the county, and I see folks burning out rapidly early in their career, like 1, 2, 3, 4 years in, where you would normally expect burnout to be happening on kind of the back end of the 10, 15, 20-year marks, seeing folks burning out really early. And so we really need to do more in getting in front of this as a profession, no matter if you're in mental health, substance abuse, psychiatry, pharmacy, whatever it is. I think we all really have to take a look at this problem that is really affecting our professional areas and then taking out people in their personal life. So what I'm going to be talking about today is kind of, you have this overarching mentality in this topic called professional quality of life. It's what we all kind of strive for, right? We all got into our careers because we want to have a professional life, a good quality life. From there, there's two things that kind of feed down. So depending on if you're doing it right or if you need some assistance, you either have compassion satisfaction, right? You're doing what you love to do. You're making a difference. You feel good about it. You're filling up your cup at the end of the day. And the next day you start out ready to go. Or you have compassion fatigue. And so that's where we're going to talk about a little bit more today. And then from compassion fatigue, in a few slides I'll show you, that actually drills down a little bit deeper from there to where we really see vicarious trauma, burnout, things that can really permanently affect you and affect your professional trajectory. So talking about compassion fatigue, I thought this was a great definition out of Tulane. It's the compassion fatigue as a state experienced by those helping people, which is most of us here, right? People or animals in distress. It is an extreme state of tension and preoccupation with the suffering of those being helped, to the degree that it creates a secondary traumatic stress for the helper. And so basically it's just exactly what it says there, right? Is that we're so involved and so invested in making sure that we're helping our clients, our patients, whatever we're doing, that it's at the cost of ourselves. And if you think about it, it's kind of the metaphor is that saturated sponge, right? It's basically we've taken on so much from our clients and from our work and so on that we just can't take any more on, including our own needs, our own family needs, our own personal needs. There's just no sponge left. And so that's when you start to see divorce, issues in your personal life, DUIs, all that kind of stuff. We start to see that other stuff kind of start to seep out. Throughout my slides, and I'll supply my PowerPoint to Lauren, and she can send it out to everybody. I put these little resource alerts. So when you get my PowerPoint, you can just click on the link, and it sends you to actually additional resources. I thought that's easier than putting together all these handouts for folks. You can basically just click on the link, and you'll actually get all the resources that are kind of applicable to this particular slide. So throughout my PowerPoint, you'll see these kind of resource alerts. Don't worry about writing it down or anything. You'll get the PowerPoint after, and just click on those links and you'll have a ton more tools after we get done. So compassion fatigue symptoms, very similar to a lot of other conditions that we might be used to treating. We have work symptoms, so work dread or avoidance, and this isn't just Monday morning. It's kind of at another level of that, right? Lower empathy, we see absenteeism. So that's a telltale sign if you're managing people or if you're managing departments or organizations, you want to take a look at that. Absenteeism, there's kind of a norm that we see in the workplace. And then absenteeism is kind of beyond that normal absenteeism. Lack of enjoyment and professional fulfillment. So again, you used to be excited to go to work, to see patients, to help clients, whatever got you in doing what you're doing. Now all of a sudden there's dread. There's, I don't want to do this, or man, I'm really wishing my client would no show today. Damn it, they showed up today. There's that dread around doing what you used to love to do. You have emotional symptoms like irritability, anxiety, oversensitivity to things that maybe before really didn't activate you, really didn't matter to you. Now all of a sudden you're kind of oversensitive, especially when it comes to someone coming to you and saying, hey, are you doing too much? Are you working too hard? Or, hey, you need to transfer some of your clients off your caseload, and you become extremely sensitive to that and extremely guarded around that. That can be a sign that, hey, you might be your sponge may be too saturated right now. Resentment around choosing the profession that you chose. I've coached a lot of professionals throughout my career. A lot of folks kind of around that 10-year mark or so are kind of like, I really wish I didn't do what I did. If I had to do it all over again, I would have done something different. Most of us have those conversations with ourselves throughout our career, but really when it's like you really dislike the choices that you made in your life and you are really actively wishing that you hadn't done what you did. That's another whole level of resentment around client care, around your career, so on and so forth. And then poor concentration and judgment. All of us in mental health and substance abuse treatment, we all know that that's a symptom that's associated with a lot of diagnoses and a lot of conditions. But again, it's just one more kind of telltale sign that there might be something going on. And in physical symptoms, don't forget a lot of people have emotional symptoms that come out and kind of masquerade themselves in physical symptomology. So you have headaches, GI upset, muscle tension, fatigue, insomnia, heart issues, all those kind of things, weight gain, weight loss. Again, it's so stuff going on inside of you that's coming out in the physical sense. And so that may be, again, a warning sign for you that, hey, that wasn't going on a year ago. What's going on? What's changed in my life? Oh, my job's gotten more stressful. We're down staff. We have a new director that is changing the way we do things. Again, those may be signs that there's something going on that you really want to take a look at. So as I talked about, we have the compassion fatigue. Well, so for compassion fatigue, if you don't really address it and you don't get it under control, it moves on to other issues. And as you can see, these are even more serious conditions that can really take you out of your career, really take you out of personal satisfaction in your personal life, and really affect you, overall as a person, as a therapist, as a counselor, as a leader. These can really be kind of, I call them career enders. So you have either burnout. So if you didn't get your compassion fatigue under check, you're going to either move into burnout or you're going to move into secondary trauma. So let's talk about secondary trauma first, because that's the most serious of the two. You have pervasive cognitive and emotional changes in meaning and sense of self. See that a lot in first responders. You see that just, really permanent changes to your cognition, to your emotions. You're almost dead inside, people have said. They've just seen body after body, or military folks that have gone off and deployed. They come back and they say, nothing activates me anymore. I've seen everything. And there's really this kind of sense of emptiness inside emotionally. Secondary trauma, stress, or vicarious traumatization. This can, again, if you're working in a field where you're being exposed to this information. In my early career, my early life, I worked for the coroner's office. I was one of the people who came knocking at your door late at night when somebody died, and I asked you to come with me to the coroner's office to identify the body. Saw lots of dead bodies in my life, in my early career. And that really affected me. And I had to really kind of take a look at that, because not much activated me. I've seen, after you see accidents after accidents, I was like, that's no big deal. I've seen worse. And I was like, well, wait a minute. That's not good. That's not good that I don't even get activated by a horrific fatal crash, because I've seen far worse. I should be activated. You should be activated. So if you're in these areas where you're getting extreme trauma saturation, you really want to make sure you're doing self-care. You're really making sure that you're connected with your own coach, therapist, counselor, peer group, whatever it is. Make sure that that is under control, because that's pretty toxic stuff there. And then just like we would see with post-traumatic stress disorder is kind of the re-experiencing hyper-arousal, hyper-avoidance, not going to areas like if you're on the wellness crisis response team, for example, let's say you're out in the field and something horrific happened, maybe not wanting to be in that particular part of town anymore. Whatever it is, it's just what we would normally say that sounds like PTSD. Well, again, that's kind of you becoming numb. You're really kind of becoming overwhelmed with something, and you're just not able to handle it anymore. So you basically just shut yourself off from it. So secondary trauma, it does qualify for a diagnosis of PTSD in the DSM-5. It's often a slow onset. And like I said, it's kind of it kind of builds from compassion fatigue. If you get compassion fatigue in check, which we all experience compassion fatigue, it's actually a pretty common phenomenon in our profession. But if you can get that under control and keep it under control, it stays like that and it ebbs and flows from there. But if you don't, it kind of moves, like I said, into the secondary trauma. And it can really have a really distinct effect on you, on your caseload. Things like an incident, a disaster, a shooting, those kind of things can move you quickly into secondary trauma. And like I mentioned, what with the research is kind of saying, and again, I hate that I'm kind of pushing us all into 30 minutes, but what the rule of thumb is, basically you're looking at the four week mark. So you had something, you're having some stress at work, or something happened at work. And if it's been about 4 weeks and you're still experiencing this intrusion, avoidance, cognitions, things like that, that's where you're probably going to want to talk to someone, maybe reach out to EAP services, reach out to your peer group, whatever it is, and kind of talk through this. Because again, that's that warning light that at 4 weeks, if it's still going on and you haven't gotten under control, it's about to take hold. It's about to significantly plant some roots that you're gonna have to really deal with later. So really, you want to kind of keep that as your guidepost. If you're supervising folks, if you're out there in the field working with your colleagues, again, just making sure that you're really doing that check-ins periodically and not waiting for 6 weeks or 2 months or 3 months or whatever to do retreats and check in. It may be too late at that point. That 4 week mark is a very important threshold that folks are that we want to go and keep a watch out for. So what is burnout? This is what I want to mainly finish out our presentation with today. This is really what affects most of us. here in the room is that this is a burnout. Burnout is classified. It is an ICD-11. It is recognized by the World Health Organization. And basically, it's a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. That's pretty much what WHO and ICD-9 identifies it as. And again, as you read that, we're all going to say that's happened to us or it's happening to us. We know folks that are affected by that definition. So that's really what we're talking about today. It's recognized as a serious occupational health condition in most sectors. So most EAPs, I think all EAPs, see that as a significant issue. And so certainly have resources for that condition for burnout. As I mentioned down there, resource alert, feel free to click on that when you get the PowerPoint. And there's some great resources for you and for your teams. What I wanted to highlight on this slide is just that this is not a phenomenon that's been around from our grandparents and our parents' days. This is a fairly new phenomenon. Only about 50 years ago, in the 70s, it was actually coined by a psychologist, and he actually referred to burnout as referring to stress and exhaustion felt by those helping professions. And so that's what we're saying. This is a fairly new phenomenon. So really it's still evolving how we deal with it. The tools that we use continue to evolve. It's not something that's been around for 100 years. And so it's really neat that, that it continues to kind of be a fairly new thing that we're looking at in our fields, in our professions. And there's a lot of hope. There's a lot of hope around it because, again, it's something that's, new and still being researched. Wanted to throw out some statistics for everybody, just so kind of see where things are in the state of the pandemic and kind of as we come out of the pandemic. In February 2021, some research came out. Millennials, 59% of millennials, 58% of Gen Zs, and 54% of Gen X had similar burnout rates. Whereas baby boomers, had about 31% of burnout rates. And so we could all probably argue this and hypothesize this probably the rest of the day about why that is. But the majority of folks that are entering or are new to the workplace are in those first three categories, right? These are folks that are either new career, early career, or have been in their career for a little bit of time. And so they're obviously at super high risk for burnout. So again, if you're supervisors, if you're directors or managers or whatever, keeping that in mind, that if you have staff that fall into these categories, they're experiencing significantly higher burnout rates than, say, you might be if you're a baby boomer or folks that have been around a little bit longer. Employees struggling with burnout, about 63% more likely to take a sick day and about 23% more likely to visit the ER. Again, absenteeism is usually the first indicator. I tell people if you're watching absenteeism at work, call out rates, now planned vacations, planned sick time, all that kind of stuff. We're not talking about that. We're talking about call outs, no call, no show, those kind of things. That is where you're going to want to be paying attention. If you have a staff that's starting to do that, you want to get in there and figure that out, because that is your first warning sign that something's about to get a lot worse. And some of the another piece of research I wanted to highlight is nearly 3 in 5 employees report negative impacts of work-related stress, including lack of interest, motivation, energy, about 26%, and a lack of effort at work, about 20%. So fairly recent research that came out during the pandemic. So 3 in 5 employees are being affected by burnout and being affected by stress at work. On the research alert there, if you want more kind of infographics, that's where you'll get those from. But I wanted just to highlight this for folks in the meeting today. 52% of US workers say that they're stressed at work on a day-to-day basis. And as you can see, 95% of HR leaders blame burnout on an inability to retain staff. Most of us on this call know that we're in a staffing crisis in our profession. We're having a hard time attracting and retaining good staff. And burnout is another source of problems for us. So if you're already struggling with that, keep in mind that you may be putting more on your staff that could be pushing them to be one of these statistics. So folks might be leaving because of opportunities, but you may be burning out your staff by putting too much on them because you don't have enough staff. And I know the question always gets is like, well, how do you deal with that? And I don't know the answer, because again, we don't have a lot of staff laying around that are, wanting to work in our profession right now. We all are going through staffing crisis. I have positions in my department I can't fill. And these are, county government jobs. Where I came from at the state, we had tons of 6-figure positions we couldn't fill. So I get it. Like, it isn't just because the job isn't attractive. We just don't have enough people out there to do the work that we're doing. And so again, just keeping that in mind, that may be loading into burning out your existing workforce. Some strong contributors of burnout. When you think about your staff and think about yourself, these are things that we typically kind of look for as reasons why staff usually consider themselves burned out or they burn out. Lack of control. So an inability to influence decisions that affect your job. And so I like to think that most of my staff would tell you that I do a lot of, what do you think? I'll defer to you. What do you want to do about this? And so there, maybe you can, maybe you can't do that in your staff and as you manage. But if you can, that gives people a sense of control, gives people a sense of be able to control the outcome a little bit. You're kind of involved in your own destiny, right? That's what we're trying to get at here is, whatever you can do to help your employee or your staff or yourself feel like more in control, do it. Unclear job expectations, another big one. And again, a lot of us are in crisis right now in the workplace. And so basically we're like throwing people in, do your job, and they don't really know what they're doing. They're fumbling around. Another really potent ingredients for burnout. Extremes of activities. This could be the monotonous job, chaotic, constant energy is needed to remain focused. You're just basically like you are on 10 hours a day. Your phone's constantly monitored during the nighttime and the weekends. You really never get a chance to unplug. That's that extreme. You're always on, you're always going. Lack of social support. This is one that's been around for a long time, but I think now more than ever, it's applicable to our Zoom world. Isolation at work and in personal life are very, very potent factors in burnout. And if you think about it, most of us today, right here, we're doing this meeting in a Zoom platform. And so we're really isolated interpersonally, if you think about it, unless you're really working hard outside of work to stay connected to people, you're already at risk for burnout just based on that one factor alone. And then work-life imbalance. A lot of us do side hustles on the side, do private practice on the side, consult, whatever, teach. Well, I know most of you on this call do more than just your day job. But again, keeping in mind that you need to do kind of your work-life balance versus your imbalance, because again, the more of these that you have, the more likely you are to lead to burnout. So keeping in mind that none of us are at fault, no one is to blame here. I went through grad school, like a lot of you all on there. I went through training, professional training, and I don't know about you, but I didn't get a ton of education on burnout and how to change it and how to look out for it. I supervise a couple students out of Pepperdine, and I'm happy to hear that they actually have a class now on burnout. But in general, the students I talk to say, we don't learn about this stuff in school. It's scary. But what it tells you all is as folks are coming to your employer and coming to your organizations, they don't know this stuff. And so it's really important for us as managers, as leaders, as mentors to really, make sure that we're doing this early career stuff with our staff, because we assume everyone knows burnout. Everyone knows how to take care of themselves. You'd be surprised. A lot of students I talk to are like, wow, I give this little presentation during supervision and they're like, wow, we didn't learn this in school, and they don't. And so hopefully that'll change, hopefully. But in general, it's kind of on us, right, as leaders and as mentors to teach our staff and our students this. Many agencies focus on productivity over the well-being of staff. That's just a fact. I'm not going to make any judgments here, but we know organizations have to keep the doors open. You have to keep the lights on. And so it's pushing Medi-Cal billing, pushing productivity, and sometimes that can be at the detriment of staff. And then many agencies, a lot of the research will say that agencies that kind of focus on health outcomes are actually pretty positive, actually save money in long run. But again, it's that initial investment that a lot of folks are kind of standoffish on of, I don't want to spend all this money if I don't think it's going to result in anything. Well, the research is actually pretty overwhelming that if you invest in self-care and burnout prevention early in life, early in the employee's career or in your own career, you actually get money back in savings in cost related to keeping that employee around. So why care? A lot of folks ask me this. They're like, you know what? If a staff burns out, you just replace them. If I burn out, you know what? So be it. And so I have to remind folks, personal, family, relationship health, because again, this is affecting your home life too. You burn out at work, you're burning out at home too. You're not there for your kids, your partner, your significant other. You're not there for those that love you and who rely on you. The quality of care. We all got into this work to do good work and to help people. But again, if you're burned out, there's only so much you can do. And now your clients and your patients think you're giving them 100%, but you're really only giving them 50% or 20%. And so the quality of care starts to diminish. Most of us are bound by professional codes of ethics, CCAP, Board of Psychology, Board of Behavioral Sciences, medicine, pharmacy. We all have codes of ethics. So again, codes of ethics tell us that we should be doing quality care. Some of you are CARF for Joint Commissions accredited. They demand this kind of stuff. They demand quality. Many of you that hold certifications or licensing, many of you don't know, I serve on the Board of Psychology as one of their enforcement experts. And I just say that because most of the cases that I get assigned to me, and I have to decide, is someone needing to lose their license or not? You can probably trace most of what they did wrong back to burnout, self-care, whatever. And these are folks that literally will lose their license to practice psychology, marriage and family therapy, pharmacy. I do some work for the Board of Medicine. These are folks that are going to lose their license in their life. And a lot of the things you look at it, you interview these people and you're like, what happened? What went wrong? Why did your decision-making get so poor? And you find out they're burned out and they don't care anymore. And they're willing to make risky decisions that will affect themselves and their clients. Don't forget about litigation. A lot of folks get sued for doing not so good things. Organizations get sued. Again, this is because a lot of times you can trace this back to someone not making smart decisions because they were burned out. Organization success, reputation. We all know the organizations that don't take care of their clients and their staff. We all know those that do. And so again, a lot of this can be traced back to a culture of burnout, a culture of not taking care of each other. And as I mentioned, a lot of times this is your career ender. This is where people are like, you know what, I don't want to do this anymore. I'm done. I'm out. And they basically leave their career and they go do something else, or they end up living kind of miserable lives that they never thought that they would live. And it's kind of sad to see. So some risk factors came out of the American Counseling Association. I wanted to highlight, since a lot of us in here do treatment or counseling or do social service delivery. There are some risk factors. So again, looking at these and seeing if these apply to your organization. If you're somebody that has some of these risk factors, these are again indicators that you may want to take a larger conversation with management, with your staff. Large caseloads. And what the Counseling Association identified this as is outpatient caseloads greater than 60 or inpatient caseloads greater than 15. So I know I worked at a lot of places that were Medi-Cal clinics. I had caseloads of like 100. So I know that they exist. I know that not every organization can adhere to this. But again, if you're an organization that has ratios higher than this, then you need to be doing extra work to protect your employees and to protect yourself. If you have a trauma caseload, so a lot of folks like, I love working with trauma clients and trauma-informed care, whatever that passion is, you may have more going on in your caseload that may be heavy emotionally, may be heavy exposing you to trauma stuff. And again, that's going to be a risk factor. Back-to-back sessions. So a lot of folks in like private practice or who see like client care, you're seeing clients from 8 o'clock to 5, back to back to back to back. Not a good setup. Cumulative exposure of trauma clients. So let's say you have a bunch of long-term clients and you've really been working with them for a long time and you've had long exposure to traumatization over and over again. Again, you're getting traumatized as your client's healing from their trauma, I assure you. Lack of clinical personal supervisor input. So if you don't have a supportive supervisor or a manager, you don't have a peer support, you don't have any of that, a risk factor for yourself. Absence of any peer support, few resources, sorry about that. I just got sidetracked for a second. Sorry. Few resources to refer patients. This is one that a lot of organizations will ask me, hey, look at what we're doing. What are we doing wrong? And then you find out they only have a handful of resources, and they don't know about all the resources that Sacramento County or whatever county they're in have to offer. And so what that does is it puts that onto the staff, onto the therapist, the counselor, whoever it is, to have to find out all these resources. So you become this kind of savior complex where you have to find out all of the information on your own because your organization isn't connected or you don't know about the resources. So finding out about, what resources that the county has to offer and whatever you're involved in. So you have resources at your hands. Because again, the more you can put out to other people, the less the burden is, right? More people are helping your client than just you. And then professional isolation. I see this a lot with folks that are doing private practice. They basically have their private practice. They're all by themselves. They see 8 clients a day. They go home. They go back the next day. They see 8 clients. They go home. And they have no professional interaction. They don't have a peer support. They don't have a mentor or anything like that. And they basically take it all on. They go home and they have nowhere to kind of process it, nowhere to kind of let it out. And that's an extreme risk factor. So if you're doing private practice, even if you're doing something on the side, try to make sure you're connected with peers or mentors that you can have kind of a peer support group to be able to process what's going on inside your practice. So I'm a huge fan of, I can tell you what's wrong, tell you what to look for, but I want to give you guys some tools to go home with today. And so I'm going to go over a couple assessments. And when I say assessments, I know I'm a psychologist, and so I do assessment, I get it. These are not those kind of assessments. We're not talking about MMPIs. We're not talking about Rorschach ink blots. These are assessments that are free source. They're available on the internet. They have great reliability and validity, and you can download them. You can use them with yourself. You can use them with your staff. If you're a clinical supervisor, I encourage you to use it in clinical supervision. Make sure your staff know about these. Make sure you know about them. And don't be afraid to use them. Maybe your organization needs some help. Well, that's okay. The first step is to acknowledge that something's wrong. And this can be a good way to bring this to your management's attention, to your own attention. Maybe you just want to know for yourself how you're doing. So here are some tools that I want to present to you all today. And again, there's going to be links in the PowerPoint that you can click on and you can direct access these. So we have the Professional Quality of Life Scale, the Pro QOL. It's free. It's 30-point self-report measure. It looks like this, basically. You go online down there. There's the link. You can click on it. You can just Google it if you want. It'll pop up. You basically score it on a Likert scale from 1 to 5, and then at the end it gives you a score and kind of gives you kind of your risks, where your risks are, where you're doing good, where you need some help. Again, super helpful. If you're doing supervision, I do this with my students over at Pepperdine. They do it in the beginning, in the middle, and at the end. So we keep a thumb on where their burnout is, so they get used to doing this. I want folks to get used to like, hey, it's time for me to do a self checkup. You log on, you do this really quick and just kind of track it for yourself. One of the best measures out there, free of charge, free source. Don't have to pay any royalty or anything for it. So feel free to use that. Another great tool that I've used with folks and used at places that I've worked is the reachout.com. This is another Likert scale. Basically, it asks you kind of some things that you do. Do you do it or do you never do it? Create uninterrupted time, for example, never, rarely, just kind of on that continuum. And again, I think it's like 30 or so questions or so. And it gives you at the end, it gives you your results. It looks something like this, or 28, sorry. It'll give you a score and it'll tell you some things that you might want to consider. And so again, if you're not really sure, maybe you're like, hey, I know I'm not burned out, I'm great. Take the test and just confirm it. Just if you're doing supervising some staff, take some time in a staff meeting in your clinical supervision to do this. It's great. It can be a great team building experience, and you know what? It can be really eye opening for us as leaders, because a lot of times we think like we're doing great jobs and our staff love us, and no one wants to leave and no one's burned out. And then you do something like this, and you're like, holy gosh, I was wrong. I need to make some changes. And then you need to then take that up the chain and say, hey, we need to make some changes here. And you have some data, some actual like information that you can share with your uplines to actually get some resources in there for your organization and for your staff. Now, those two tools are great. Those are kind of the gold standard in self-care assessment. But then a lot of folks are like, what do you do with it then? Well, one thing that you can do is kind of this called a self-care plan. And again, a lot of us who are therapists and stuff, we may get this, but again, not all of us are therapists, and not all therapists know this stuff. So I want to put it out to everybody to use. There's a lot of areas for self-care. It's not just about going on hikes and meditating. There's a lot of things that can go into it. So this self-care plan, it can be super helpful. And you can basically, this is the one that I developed, that I use with a lot of my staff or a lot of my students. And you can do this, but basically you're wanting to capture other areas, because it's not just about work. It's about your psychological, your spiritual, your workplace, your relationships. There's a lot of areas that folks need to kind of take a look at when they're looking at their overall self-care. So you're wanting to make sure you do a very comprehensive overview. Another great tool that I use is the Mindtool assessment. And I think I don't have the link. I'm sorry, but you just basically Google Mindtool assessment, and this will pop up, and it's another Likert scale type thing. And it gives you some more data about where you are and kind of where you can go on self-care. I've taken all three of them together throughout my life. They have pretty good reliability with each other. You're not likely going to say one is going to say you're doing great and the other one says you're horrible. They all kind of in concert with each other. So, feel free to use one or more of them at the same time. Again, if you're trying to build a case for some resource allocation or resource expansion, this can be a really great way, again, to kind of get some money or get some resources from your upline that you actually have like data versus just like, well, everyone says that they're overworked. Well, uplines don't usually like to hear that, but hey, we did assessments, we did this, we did that. Here's the data. It's hard to argue with that. Another tool, there's the link down there. A lot of tool that I've used when I do this in conferences is the self-care wheel. Students love this. New early career staff love this. They basically do something like this and they put it up in their office or on their cubicle or whatever. And it's just a nice way for them to kind of get a reminder of things that they can be doing for all of these different areas within their life, and how to make sure that they're doing life balance. I have this as part of a larger session. When I meet with students for the first time, they do their assessments, they find out the results, and then they develop their self-care wheel, and that's kind of their guidepost while they're working and doing professional care. It's just they have something to go to. We would refer to this as kind of a safety plan, right? If we were doing safety planning with a client. This is kind of safety planning for yourself and for your own self-care. So it's a nice way to make sure you're touching on all of those different areas. So I get asked this a lot. So why can't organizations just bring in a great motivational speaker, give everybody a day off, give everybody everything, bun cakes, and everyone will be happy? Well, the research is actually pretty telling. And what we know is that person-directed interventions are far more effective than organizational directed intervention. So what that means is when HR says, this is our new self-care and this is what we're doing, and the employees had nothing to do with it and have no say in it, the results are not as robust as if employees do their own self-care, or they're actually developing their own self-care plan. And so if you're high up in your organization, just keep that in mind, because it's very tempting for folks to spend money on a motivational speaker and a retreat away for a day. And now we've done everything we can do and now everyone's great, right? We actually find that the research actually doesn't support that. So a combination of the two, combination of both person-directed and organizational directed interventions actually have the far better outcomes and more sustainable outcomes long-term with the organization and with the person. So as I talked about, how you might be able to use what I'm talking about today and the tools is basically, using as part of, after you hire a staff, consider doing this as part of a baseline. As part of hey, just getting to know you. Maybe the staff does it by themselves and they keep their own numbers. Maybe you don't want to be involved in those outcomes, but just something that you can help the employee get a baseline to themselves, so that as they do these throughout their career, they know if, hey, man, my scores are getting higher or whatever, I need some help. You're giving them the tools of insight. You're giving them tools of self-analysis that can really be helpful for them to actually know, because by the time they realize that they're in a bad place, it might be too late. So that's why you want to kind of do this as early as possible. As I talked about, I do this as part of individual supervision with my students. I do this, we go over, we talk about it. We talk about what can we do, what can we change. et cetera, et cetera. You can do quarterly assessment, quarterly, basically everyone tell everybody, hey, it's time to retake this. It's between them and their previous number. Maybe you make it part of a larger organizational thing. Again, it's just ways for folks to get insight into their issues. One of the other things is changing caseloads and clinical demands. Some of the research is basically saying, shifting up caseloads a little bit. And I know this is controversial because people are like, well, does that harm a client when you change their therapist and their counselor? And I think you have to do it from a clinical perspective and a case-by-case basis. Someone who's going through tons of trauma, who has maybe characterological disorders, yes, changing out their therapist too often can be clinically detrimental. But if there isn't that particular issue, changing up people's caseloads, so maybe folks aren't always sharing the heavy clients, the high demand clients, that can be helpful in people's caseloads. Remembering that you have a lot of early career folks joining our field right now. A lot of folks have been licensed or certified or in our field like less than 5 years. These are not folks that have been around the block a long time. So just remembering that is that we're asking a lot of folks that don't have a big foundation underneath them. And I don't oftentimes do a lot of this in like large group settings. So I wouldn't do this at a large staff meeting. I might have folks say, go home, do it. And then when we meet individually, we'll go over it. But I would not have people sharing in a large group like, well, just so you guys know, like I'm burned out, and sharing their numbers. Like it can be very isolating and it can be very degrading for folks. So if you're going to do it in a large group, do larger stuff, but have them do their individual scoring and maybe have that as part of a one-to-one check-in. So results of early assessment intervention, I kind of talked about. If you can invest early, you get great dividends in the long run. What we typically see out of the research, and this has been consistent pre and post pandemic, is decreased sick use time. And I'm not a big fan of people not using their sick time. I'll be honest. Like, again, I hope my staff will back me up here. But when my staff are like, hey, I need a day off, or I'm taking a day, I could care less. And maybe my boss will hate me for saying this, but you have sick time, go use it. If you're going to go take a 4-day weekend, 3-day weekend, I could care less. Because again, if you're taking care of yourself, you're just going to be a better employee for everybody. So I don't like to see decreased sick time as a variable, because I think that can be overvalued. Because like, well, now, she hasn't used sick time in a year. Well, I don't know if that's a good thing. I don't know if that's a really good thing. For someone to have 600 hours of sick time. I hope that folks are using it for their own personal use. Increased longevity and low departure. So again, retention rates are typically a telltale sign. Increased morale. You typically save money in recruitment, hiring, onboarding, because it takes 2 to 3 times more to replace an employee than to retain an employee. So again, if you're retaining your employees, you're not front loading all that money to try to recruit new staff. Stronger interpersonal connections at work, which reduces that isolation, which is a risk factor. And then we know that it's overall better care for clients, which is what we care most about. So you sometimes will hear this term called career sustaining behaviors, or CSBs. Basically, these are the coping skills for mental health and helping professionals. It basically is the more that you can do these things, the better off you are and the more protected you are around burnout and around issues that may take you out of your career early. So sense of humor, perceiving client material as interesting versus I don't want to read this. I think my client's boring, or my client's faking, or whatever it is. Looking at it as, hey, this is kind of interesting. I'm learning something from this client. Engaging in leisure activities outside of work, using your consultation, and relaxation. And the other thing you'll hear that's kind of coming out of this line of research and interventions is this thing called micro behaviors. So a lot of times you'll see articles, and I'll talk about, what's your micro behavior between sessions, or after you see a client, what's your micro behavior? And it can be something as simple as a quick body scan and relaxation, maybe some progressive relaxation in your chair, get up, walk around your office, grab a glass of water, step outside, whatever it is, those kind of things that break up the monotony of your day. That's called micro behaviors, and and they're linked back to this career sustaining behaviors. The more you can kind of do those things, the better off you are, because again, it's not compounding the hour after hour after hour. You're getting a little bit of a release and a relief between clients or between appointments. And I know it's easier said than done. My calendar is horrific right now. I go from meeting to meeting. I think most of you probably are the same. And so whatever we can do, micro behaviors, even if we're just sitting at the camera and we're doing some progressive relaxation or something in our body or doing a body scan, that can be extremely helpful. Last thing I want to share with you, and again, you'll all get this PowerPoint, but there's a ton of tools here. And I just mentioned a few of them, but there are a ton of tools, a lot of things that you can do as groups, as departments, as organizations, as individuals. A lot of things I talked about, the assessments, there's links there as well. But definitely, if you have a chance, take a look at these links when you get the PowerPoint. Some of it's out of Europe. Some really great research is being done out of Europe right now on this topic. They're kind of ahead of us on it. And same thing with Japan and China are out doing some good research on this as well, trying to combat the issues of burnout and vicarious trauma. So take a look at those links if you have a chance. And then most of you already know who I am, but feel free to reach out to me, send me an email, and I will definitely answer any questions that you have or send you any information I could possibly send, and so on and so forth. So Janet, back to you. Thanks so much for allowing me to do this.
Thank you. Does anyone have any questions or comments for Andrew? You know, this is a very important topic, and, you know, especially these last, 2 years in every aspect of essential workers and healthcare workers and other in this throughout this pandemic, has been especially trying, to combat, the compassion, fatigue and managing self-care. It's like, self-care, what is that? So, it's always important to be, reminded about that. Andrew, I did have a question for you. So you had, in one of the researches, it said that millennials, Gen Z, and Gen X, their burnout numbers were higher than the baby boomers. What do you think that's attributed to?
Yeah, so some of the research, and I'm actually glad that I just see one of my colleagues on the email or on the meeting right now, Andrew Wakefield, and I presented this topic around the country. So I'm glad he's here. So Andrew, feel free to jump in as well. I know you're an expert in this as well. But I think the research that we were looking at on that is what that highlights is folks that baby boomers have kind of been through things, and they've seen an outcome, and they've recovered from it, and they have this perspective on it because they've kind of been through a lot, right? And so the earlier that you are in your career, you haven't had that perspective that things get bad, they get better, they get bad, they get better. And so there's a little bit of that. So the older we get, we call it kind of wisdom, right? We have that perspective of like, things will get better, like we'll get through this as well. If you don't have that, you tend to be kind of in that moment, you may not have that positive outlook on life or on what's going on in work. And that may be adding to why you have more burnout. Now, and who knows, maybe we'll see in another 15, 20 years, that'll play out, or we'll see that there's another reason why millennials and other generations don't have or have higher burnout rates. It's just the research is super infant in that particular area right now.
And then are we seeing, higher numbers in terms of, suicidal ideation, attempts, or, like with hotlines or anything, with essential workers, healthcare workers, or, just in general?
I know the suicide rates have stayed pretty consistent. There's been some bumps here and there, but as for like the use of crisis lines, I have to defer to my colleagues on that. I'm not sure on that. Okay.
Well, again, I personally also appreciate this information. We all need to be reminded about the importance of self-care, to, keep us, our batteries recharged. I really like that. That analogy, so that we can continue our work that we are doing in our community. So thank you again, and we'll keep pushing forward. And
right,
so are there any other questions or comments or anything in general? They are going, there is in the chat, you mentioned sharing the slides, and how are you, how do we access them? That's the question.
Lauren, do you have a preference? You want me to throw it in the chat, or do you want to send it out, or how do you want to do it?
So
yes, I'll send out a follow-up email, including them in there.
okay. Okay, thank you, Lauren. And so, I'd like to, again, thank all of our presenters today for very informative topics. And again, I like to remind everyone that, we will be sending out a survey. So, please look for that email. And our next coalition meeting is scheduled for July 18th at 2 p.m. We are the executive board of the SAC Opioid Coalition. We meet to put together some topics, but we also want to hear from you folks as well. If there's any speaker, if you have any resources that you would like to see at our coalition meetings, please feel free to reach out. And the email that Lauren will be sending out will have information on how to contact us. So you can, just let us know your thoughts that, we could make this, these meetings very meaningful as the one that we had today. So let me check the chat. No, nothing else in the chat. So again, thank you for your time, and everybody stay safe and take care of yourself and be kind and all those good things. And we'll see you soon. So everybody have a great afternoon. Goodbye.
Thank you.